This is Dr. W. Michael Park, staff surgeon at the Cleveland Clinic, speaking on arterial restoration. Typically, when we talk about revascularizing arteries, we talk about bypass and intervention. These are the two modes of revascularization that are familiar to everyone. Endarterectomy is actually an earlier method of revascularization. It's seen today most commonly in carotid and common femoral endarterectomy, but in the past, at the origins of vascular surgery, endarterectomy offered actually the only means of revascularizing occluded arteries, including the aorta, iliac arteries, and femoral arteries. Remote endarterectomy is a minimally invasive method of restoring patency to native blood vessels by removing core of these atherosclerotic plaques from typically a single incision, sometimes two incisions, and same to restore the patency of native vessels. And again, it represents a third method of revascularizing arteries. We see a lot of complex vascular disease here at the clinic, and this includes multi-level occlusive disease, failed bypass grafts, failed stents and interventions. These patients typically present with a lack of venous conduit. They suffer from multiple medical comorbidities and often from concurrent infections from previous surgeries. When they present, we are left with what I term terminal options in terms of revascularization. These include multi-segment vein bypasses, cadaveric vein bypasses, prosthetic vein bypass, use of a sequential arterial pump, amputation, and hospice care. Remote endarterectomy is done in this illustration from exposing the occluded artery, making an arteriotomy to dissect the leading edge of atherosclerotic plaque. Then a ring dissector is introduced around the plaque, and this is introduced and sent distally under fluoroscopy. This allows me to mobilize the plaque to where the artery regains its patency. I can then cut the plaque. Sometimes the plaque just mobilizes itself because I've reached a good end point, and the plaque comes out, and then the artery is closed with a patch. These are the instruments that we use to restore patency to these vessels. And illustrated in the bottom right panel is the cutter device, which uses two rings in a scissoring fashion to cut the plaque distally. And this is an example plaque that I've removed from a patient who had multi-segments of occlusions, including plaque from the external iliac, common femoral, profundifemoral, superficial femoral, popliteal artery, anterior tibial artery origin, and tibioperoneal trunk. This shows you how much plaque I can remove from someone. And this is that patient. The patient original arteriogram is on the left, showing multi-segment occlusive disease. She had no vein left for bypass conduit purposes, had tissue loss and rest pain. I was able to revascularize her all the way from basically the aorta down to her popliteal artery by removing all of these occlusive plaque material and restoring her arteries to their original patent condition. What's also restored is again the native vessels are restored so that they can actually, ironically, undergo future interventions if necessary. The elasticity of the vessel wall is often restored because it's the plaque that decreases the elasticity of the wall. I find that this actually may play an important part in maintaining the patency of these vessels, that when the elasticity is restored, there is a component of flow that occurs during diastole that maintains flow, and also it maintains patency through the biological effects that it may have. Collateral vessels are preserved. You can see in the angiogram on the right the collateral vessels off of the superficial femoral artery are preserved. These are lost in stenting and often bypassed further down below and not play a part, but actually I think that these collateral vessels do play a part in maintaining the patency of these interventions in particular. And again, interventional options are restored. So if this patient were to develop a restenosis down the road, this can be ballooned or stented, much as in the original state. This is a illustration. It's a composite CT angiogram of a patient who underwent an aortoiliac and common femoral endarterectomy before and after intervention. We also run across a great number of people who've had what we term full metal jacket stenting for extensive occlusive disease of the femoral artery. This kind of procedure is done in patients who are considered high risk. The outcomes in this kind of long segment stenting are inferior to short lesions, but it is an option. This patient here, illustrated here on the CT, has occluded stenting of his entire femoral artery and the stump of an occluded bypass graft. With reocclusions of these stents, reinterventions are typically not durable, and so you can expect maybe 2 to 3 years patency on average for these long segment stents, and then reintervention adds another year or two, but then at that point that's it. These bypasses can often fail too. This patient had a hypercoagulability and vasospasticity, resulting in his occlusions, and also suffered from wound infections. His revascular options were limited due to lack of vein. This is the first person I actually attempted this kind of long segment removal of stents. I was able to remove all of his stents using remote endarterectomy and restored his femoral artery to its original condition. He maintained his patency for the 3 years I followed him in my practice in Iowa, and he was quite happy with the results, as was I. This led me to investigate further this option of removing the stents, and you can see here this another similar patient with stents in the left leg. The specifics of the method I'll be publishing in a paper, but we have different tricks up our sleeves to get these stents out. But you can see here the wire here is used to loosen up the stent off of the artery, and then the ring is run down. A good endpoint, if it's achieved, allows us to not have to stent the distal endpoint. You can see here on the top right panel the stent coming out, and ex vivo on the bottom right panel. The patients with infections are often challenging, and this often limits the kinds of revascularizations we can do. The principles of revascularizing include using native tissues and applying muscle flaps. This is a patient who was transferred, one of my first patients I did here at the clinic, with a graft infection, a fem-fem graft infection. This was actually a second fem-fem bypass graft in this patient. And the physician, on draining this, resected the distal anastomosis of the graft, but left the rest of the graft in place, packed the wound, and sent the patient over for us to help take care of her. This shows a CT scan showing the older graft above, which was still well incorporated, and the lower graft, which was infected on both sides. In fact, on the inflow side, there was also an abscess. In this kind of patient, we would typically think about using native vein, using deep vein to perform a fem-fem bypass using native vasculature. But looking at her anatomy, I thought that there was a chance that we can restore flow from the native circulation. I was able to actually remove not just the iliac plaque, but also an occluded wall stent. I won't go into the technical specifics of it, but the wall stent tends to be a little bit easier to remove because of its the way it's built. But that said, it did come out, and we were able to restore patency on that side without having to use any prosthetic or native vessel conduit. The failure modes on these restorative procedures, these remote endarterectomies, includes reed stenoses. These tend to be isolated and randomly distributed along the revascularized artery. That requires us to follow these patients on 3 to 6 month intervals initially, and then probably once a year after we've established that the patient will remain patent. These lesions are amenable to ballooning and stenting if necessary. I've seen thromboses, in particular in people who continue to smoke. The difference between this and the kind of malignant thromboses that can occur with a prosthetic raft, especially a PTFE, is that only what's been reopened tends to thrombose, and maybe even less because of the collateral vessels being present. That's what I call a soft landing. The patients have the opportunity to undergo thrombolysis or another revascularization as needed. The other risk factor for failure is single vessel runoff. So smokers with single vessel tibial runoff tend to do the worst, and these patients I generally anticoagulate. My threshold for anticoagulation is fairly low for these patients postoperatively. In conclusion, this has been, for me, a durable third option for revascularization. It is equal to multi-segment vein and PTFE bypasses. Clearly, the gold standard still remains a single segment of good vein, but typically we don't have that in our patients. Minimally invasive, it is minimally invasive in that we don't have to harvest multi-segments of vein. And typically, most of these procedures can be done through a single groin incision, plus or minus a cut down on the thigh. This greatly shortens the length of stay compared to typical bypass surgery. Because we use native tissues, this can be done in severely infected fields even, and no bridges are burned. No options further down the road are eliminated by this technique. And finally, this is what makes me awfully excited about this. This represents restoration of these blood vessels to close to their original state. Not all patients can undergo it, but in those patients who have the right anatomy, this allows us to turn back the clock, as it were. Thank you very much.